So recording has started, and Krupa, over to you. I'll.
Okay, thanks, Amaya. Good afternoon, everyone. I'm Krupa. How are you all? I hope you have eaten well and I can put you off to sleep. All right, guys, let's get on with this. I'm going to be talking a few words about rapid sequence induction. Basically, we'll start off with the introduction as to what the airway assessment would be and what happens in elective and emergency. Intubation, what's normal and what's rapid, and what is modified rapid. Induction drugs, muzzle relaxants, analgesics, probable complications. A few words about the National Audit Project 4 studies, the challenges which are unique to our environment, and a brief summary of this. So let's start with the introduction. Airway. So what's airway? Basically, it starts with your ABC of your examination. So anyone and every one of you guys who go examine the patient, you will deal with airway as a first part of your component. Assuming it's patent, you move forward. So what constitutes an airway? Everything from the nose to the alveoli, simple in simple terms. Now, how do you secure your airway? Firstly, you try and maintain a patency with your nasopharyngeal, oropharyngeal, or your Goodell airways. Next, moving on to LMA, IGIL, and when we say a secure airway, that means it's endotracheal intubation. What's RSI? I'm going to talk with it in a bit more details as we go forward. Well, just a picture of the respiratory system. Now, when we're talking about airway, you would always want to imagine something called as an airway assessment. Without knowing what you are going to get into, you will not try and intubate a patient. So, airway assessment, basically, this is very luxuriously, very leisurely done as we anesthetists see our patients in a pre-op assessment. But that's not the case every time you are in ED or on the ITU. Half of your patients are either sleepy, comatose, or drowsy, or there's something else precluding their consciousness levels, which will not make airway assessments easy. And make intubation difficult is the presence of a semi-rigid collar, probable head blocks, and a tape to immobilize the C-spine. And you will not be able to see a larynx on these directly on direct laryngoscopy. And that's why I think all of us have very conveniently taken over to video laryngoscope these days. Well, so when I say about an airway assessment, I don't think every one of you would be doing this, but there are gross pictures. When you look at a patient, you would identify, yeah, this person could be big. Like, let's say if it's just a big patient who is obese, a big hanging chin, short neck, I easily can say this is going to be difficult. So you look at external habitus, head and neck anatomy, a small mouth, teeth, overcrowding. Yes, there's probably no space to maneuver your laryngoscope. Any jaw abnormalities like micrognathia and tongue, it's a big one, or a swollen in case of burns, everything makes it difficult. Mouth opening in terms of interincisor distances, you measure it and you rough measurements. Basically, you need to have space or a space to leverage your laryngoscope and your tube. That's why we are more worried about it. M is a Malampati classification, which anesthetists use. I've just got a picture here. I'm going to be very brief on this. In class 1, there are 4 structures which you can see. That would be your starting from the deeper structures to superficial structures. It would be your glossopharyngeal folds, uvula, hard palate, and the soft palate. As you go progressively to higher number, some of the structures within the deeper tissue starts disappearing. It's simple as that. In class 3, you will not see your glossopharyngeal folds. In class 2, sorry, and in class 3, you will only be able to see a soft palate and a hard palate. And in class 4, you can just see a hard palate, which means to say, yes, you are in for difficult intubation. Going back to the previous slide, look if there's any obstruction, if any head and neck abnormalities, cancer, surgeries, laryngectomy, if they have radiation scar, tracheocutaneous fistula, all of these could probably give you a visual hint that this could be not easy. Probable stridor, which could probably say either there is a mass sitting somewhere there which is obstructing, or it's an edema, a foreign body burns, epiglottitis. All of these are bound to make it more difficult. And last but not the least, some neck mobility. If you can't move the neck, you can't maneuver your scope, because all of these assessments you do, ultimately, if you have to maneuver anything in the neck and in the airway, you would need your neck to move. The basic thing would start off with your chin lift and your head tilt. So if the neck mobility is reduced, you will be losing most of your airway and patency, I'm sorry. Yeah, we've just gone through this, so I'll not repeat this slide. I'll come back to this. Okay, so basically what is rapid sequence induction? All this means is you will try and secure the airway as soon as you can. As compared to what we do on a daily basis as anesthetists, you have all the time. You wait, you pre-oxygenate, and then you secure your tube at the end of it. There is no rush. We do rapid sequence induction for patients who we think who need an airway protection, which is imminent at some point or the other. Patients will require RSI or isolated head injuries who are hypoxic with a GCS of 5 probably, or even 8 is basically for airway protection. Facial injury, blood in the pharynx, mesitospasm, some bilateral mandibular injuries, chest injury which requires urgent ventilation, or it could be some kind of a pulmonary contusion, drain pneumothorax with hypoxia, asthma who's completely exhausted. And trust me, they are not the easiest people to put them even on the ventilator. And status epilepticus unresponsive to other therapy. On the other spectrum of this is a comatose patient who is perfectly maintaining their airway, but they are quite drowsy. So where do you stand at this point in time? You will have to intubate them, but it is not required immediately. This is one category, but the others are immediate and you have to get going with it. Well, when we say RSI, it's all about pre-filling patient's lung, having with a high concentration of oxygen, a cricoid pressure to occlude the esophagus. We use cricoid as the cartilage because it's a first complete ring in the tracheal anatomy and it can give a proper pressure against the vertebral body. That's why it was used as a cartilage of choice. A rapid pre-calculated doses of rapid onset sedative and neuromuscular blocking agents, particularly thiopentone and succinylcholine, is what we most commonly end up using, which end up inducing prompt unconsciousness and paralysis. Avoid artificial positive pressure ventilation by mask, and ultimately it's inserting a cuffed endotracheal tube without any unnecessary delays. Release the cricoid pressure only after the cuff is inflated and the ventilations begin started through the tube. Now, there is something called as a modified RSI. There is no proper consensus on this, but it is basically to improve the patient's physiological stability during the procedure at the expense of a theoretical increase in regurgitation. Modifications can be in the form of alternative drugs, omitting the cricoid pressure, lessening of the pressure, or applying it before the ventilation has started. Now, there was a survey conducted between anesthetists, trainees, consultants, and various grades as to when is the ideal point when they start applying cricoid pressure. There are varying answers, but from what we practically do most of the times, I'm sure will be no number of variations again, is you tell the patient that they are going to feel a bit of a pressure even before they've fallen asleep. And as soon as the induction agent is in, you will start keeping that pressure. Initially maintain it at 10 newtons, that's about 1 kilogram of pressure on the cricoid, and go up to 30 newtons, that is about 3 kilograms. So once the induction agent is in, or once they've lost their consciousness. Now, I think this is one of the checklists which most of you, if you're working on the ED or even on the unit, you would have come across this, is because this is one of the intubation checklists we always have. These 4 P's are important. Prepare the patient, prepare the equipment, prepare the team, and prepare for any difficulties. But when we say prepare the patient, obviously you need to have a very reliable access. Not often on the emergency department you can find that kind of a reliable access. Even intraosseous cardiorespiratory arrest is inevitable. You can use that. Try and optimize the position. Sit up, make sure you try and get that sniffing air kind of a position to align all your oral axis, pharyngeal axis, and your laryngeal axis in line so that you can see where your laryngeal inlet can lie. Use a hard mattress. On the airway assessment terms, identify the cricothyroid membrane as a contingency plan. Would an awake intubation be a plan? But this would critically be an important decision, because we are doing an RSI. We don't have enough time, and that's why we are doing this as an airway protection. So that would be one of our last options to consider. However, you can try and request a senior help at that point in time who's more airway experienced. That could be another option with you. Optimal pre-oxygenation is ideal 3 minutes or with any entirely oxygen concentrations of more than 85%. You can consider a CPAP or an NIV as it continues. Nasal oxygen, high flow, nasal oxygen is one which can be continuously on. Nasal specs can be kept on. Make sure the patient is stable in terms of giving either fluid, pressor, inotrope, start whatever you need to. If you guys have worked with anesthetists on the emergency department or if they're intubating outside, with their induction, they usually will carry a syringe of a vasopressor with them. Not an inotrope, but a vasopressor. This is just as a backup. As they're giving induction agents, your blood pressure tends to fall, and that's one of the reasons why they're always prepared before they can even start searching for anything else. If there is an NG tube, make sure it's aspirated, and as a protocol on the ITU, I've seen that they always keep the NG empty if you have to try and do it, and they aspirate it. And is delayed sequence induction an option? We'll think again at that point in time. Any allergies like burns or succinylcholine apnea, one of those, they can all cause increase in the potassium, which can be quite harmful to the patient. You can prepare the equipment, that is basically apply monitors. Basically what we need is pulse oximeter, a waveform, end-tidal carbon dioxide, ECG, blood pressure. This is something which is very vital to all of us, and we want to see these on the monitors. Check your equipment, have at least 2 tracheal tubes with their cuff checked, direct laryngoscopes, which are 2 of them working. As I said, most of us these days, we fancy using a video laryngoscope just so that everybody is seeing what you are doing and everyone can give their opinion if you think the tube is not in place. So video laryngoscope does play an important role. You can have a bougie or a stellate, never underestimate that. A working section always by the patient's head end. Yes, and supraglottic airways as contingency plans, nasal and guttural airways, a flexible scope and an entry, not always, but yes, it would be desirable to have. And I think one word which most of us would dread at is front of neck access set. Check the drugs, consider ketamine, relaxant, pressors, or inotropes, and maintenance of sedation, because after intubation, you would need that. Prepare the team. One person should be assuming the role of a leader. So you have a team leader, a first intubator, a second intubator can be a person who can assist them, or it can be just as a standby who would just be there in terms when things can go wrong, or hopefully just as there. Someone to give cricoid pressure, an intubator's assistant, some drugs, a person to monitor the patient, one would be a runner, and make sure the whole team knows who will be able to perform a front of neck access should the need arise. Next question you have to answer is, who will we call for help? And always maintain the time, because when things start going wrong, you would have lost track of how many minutes has it been since a patient is desaturated or has been under this stage. So you will be losing track of time. So it's important that someone just notes this. You would be surprised, trust me. Can we wake the patient if at all intubation fails? Would that be an option in case of our head injuries, where the patient can't breathe, he has a pneumothorax, a failed breathing, hypercapnia? The answer is unlikely to be yes. Verbalize your airway plan. Always have plan A, B, and C. Plan A is tracheal intubation, oxygenation. Plan B is rescue oxygenation. Plan C, or that is plan B and C. And plan D would be your front of neck access. We've just gone through this, and just as an aid, how do you size your equipment for endotracheal tubes? For a cuffed tube, which most commonly all of us use, is a formula that is age divided by 4 plus 3.5, and the depth of insertion, anything for more than 1 year, would be age divided by 2 plus 12. And laryngoscope. Laryngoscope, you can use the video laryngoscope, which obviously comes with the blades attached to it, and you've seen most of these are being on the unit. However, there's something else called as a Miller blades, which are straight blades, and these are designed to directly lift the epiglottis. We would prefer to use them in less than under a year because of their floppy epiglottis and laxity of the ligaments. And the MAC blades are curved, and they sit in the vallecula and they lift the epiglottis indirectly, but put pressure on the glossoepiglottic ligament. When you are in doubt, always try and use a bigger size, because smaller obscures your vision and you'll probably not be able to lift off the epiglottis. So if at all there is a doubt as to which one you want to use a larger size blades. Um, this is one from the Difficult Airway Society guidelines for tracheal intubation critically ill adults. First is obviously pre-oxygenation, your checklist, which we've gone through, making sure you have a head-up position if possible, assess any airway and identify the cricothyroid membrane, waveform capnography, pre-oxygenation, optimization of the cardiovascular system, and share the plan for any failure if you have, thinking that it could go wrong. Plan A would be obviously tracheal intubation, and we say it's a maximum laryngoscopy of about 3 times, each time with some maneuvers done which can make a laryngoscopy successful. It could be either a proper another head extension flexion what you need. It could be a burp maneuver on the trachea, that is a backward upward push of the trachea of the from the external side to just see if you can mobilize. If the cricoid pressure is being applied, you can ask them to release a bit of a pressure at that point in time to get your tube or your scope inside. If that fails, hopefully you don't go there, but rescue oxygenation is plan B and C. It could be with either a supraglottic airway or igel, any of these, maximum 3 attempts. You fail, you know what you're going to do next. That will be obviously a front of neck access. Any questions so far? I'm assuming this chaotic silence means either everyone knows or we are
No
asleep. Thank you.
questions from my side.
Thanks, Amaya. Right. In terms of plan A, you have to prepare oxygenate, induction, mask ventilation, intubation. Make sure that there's a team leader who has already assigned the roles, and share the plan as to what it would be, and make sure you have any comments. You would always have shared your points as well. Any further expertise should be decided at this. Prepare your equipment and drugs which are necessary. Ideally, yes, we did discuss about the sniffing air position, and in terms of cervical spine injury, you can have a whole bed which can be tilted up. In obese patients, a stacking of the pillows to get the external auditory meatus to the sternal notch in alignment would aid it. And optimal position improves upper airway patency and access, increases the FRC, and may reduce aspirational risk. By FRC, I mean it's the reserve lung volume what you have, and this the functional reserve volume. You can increase oxygen content from your just tidal volume to up to 2 liters because of this, by just denitrogenation of the functional residual capacity. And ensure that the bed mattress is as firm as possible to optimize the cricoid force, head extension, and access to the cricothyroid membrane to aid this. Monitoring, we discussed. Pre-oxygenation. Now, the problem lies is critically ill patients are uniquely liable and vulnerable to hypoxemia, but standard methods of pre-oxygenation are only partially effective. In the absence of respiratory failure, pre-oxygenate using a tight-fitting mask with 10 to 15 liters of 100% oxygen for at least 3 minutes. It would be ideal to have an end-tidal oxygen concentration of at least 85%. In the theaters, it's quite easy because your anesthetic machine will show you when you're getting it, but on the other part of the areas, it's not so easy. You don't have those machines which are as complex to help you aid these. In hypoxemic patients, CPAP and non-invasive ventilation could be beneficial. However, gastric distension can happen when the airway pressure exceeds more than 20 centimeters of water. Yeah, we discussed this already. I'm not going to go through this again. Well, drug choices. Right. The drug of choice mostly is all dictated by how stable your patient is. Most of the patients which we see on ED for some other reason are hemodynamically unstable. So either do you want to start your vasopressor or inotrope earlier peripherally, or do you want to use a ketamine, which is very a sympathomimetic agent. So it stimulates your sympathetic nervous system. So it gives you a bit of a stability as well. So you could use that. The other options being thiopentone and propofol. Thiopentone is used in the dosages of 3 to 7 milligrams per kg, propofol 2 to 4 milligrams per kg, ketamine 2 to 2.5 milligrams per kg. Etomidate is another drug which has been mentioned, but because of the reserves of the drug, we generally don't use it because of this adrenal suppression. We would love to use an opioid. If you see, there's a mixture of analgesic, or your induction agent and a muscle relaxant. This is what has always been a core component of anesthesia and analgesia coming in hand together. We would prefer to use an hypnotic like an opioid like fentanyl in the doses of 2 to 3 mics per kg. However, as an anesthetist, people or who's taking care of the airway, they are aware that it can lead to hypotension, chest rigidity, some cough or itching as well. The rationale behind using an opioid would be it reduces the induction agent dose and the hemodynamic changes which take place, and it minimizes the rise in intracranial pressures. And
This time.
yes. Okay, I'm back on. Sorry, I don't know what happened. Yeah. Muscle relaxant we end up using only because it improves intubating conditions. It can aid with face mask ventilation, either a supraglottic airway insertion. It optimizes the chest wall compliance. It reduces intubation attempts, and it also abolishes the airway reflexes, especially a laryngospasm. So these are one of the things we use. Historically, succinylcholine has always been used shorter acting, and it gives you an excellent muscle relaxant. These days, obviously, rocuronium is in place, and we have Sugammadex readily available to reverse it should the need be. We don't see why we need to be going back to using succinylcholine. However, having said that, the doses for succinylcholine would be, we have something, I think most of you have read this in pharmacology, about the effective dose 95, which is needed for the doses of the drug to be acting basically. So for any intubating conditions, so we would at least need 2 times the ED 95 for the drug to act within a span of time. When we are talking about RSI, we try and aim to secure the tube at the end of 90-second period. So you should have had your pre-oxygenation before that. Once you start giving your induction drugs, your muscle relaxant shouldn't take long enough for you to lose that precious window. So we end up using rocuronium in an intubating dose of 0.6 milligrams and succinylcholine as 1 milligram per kilograms if at all used. Coming to plan B and C, it would be rescue oxygenation using a supraglottic airway or IGEL or a face mask after a failed intubation. One optimal attempt or a maximum of 3 attempts with each, with either SGA or face mask recommended in the plan B or C before declaring it as a failure. And I'm not saying this is by DAS guidelines. Following failed intubation, usually the airway person attempting an SGA placement would be interspersed with an attempted face mask ventilation. Now, an Australian anesthetist came up with this something called as a vortex approach. This identifies a green zone and a which is of relative safety, and the vortex as the converse. While within the vortex, you try and attempt intubation, either a supraglottic airway placement. Again, you can see vaguely the marks over there on the left-hand side with an SGA, and with on the right-hand side, you can see your endotracheal tube. Sorry. Now, with this, while you're in the vortex, basically SGA placement, face mask, ventilation, and alternating continuum, they all culminate, try and get the success. Because if you can look into it, why this was designed again was, if you spiral down, you don't have anything else, but you will end up reaching the front of neck axis. This is a bit scary as you get there. Spiraling out of it is easier as soon as you are able to oxygenate the patient. So this was one of the views we had for it here. This is another picture which shows spiral in or out with endotracheal tube, a face mask, and a supraglottic airway. Now, complications of an attempted intubation in the emergency department would be failure to intubate, hypoxia, unrecognized esophageal intubation, aspiration of stomach contents, hypotension, awareness, arrhythmias, and unfortunately cardiac arrest. Now, all of these complications we've seen, but what are unique challenges to intubation within outside of a controlled zone? I'm not going to deal with it, but then they can be broadly classified as non-theta settings, patient factors, and human factors, or the person who's doing it. This is all from a study called NAP4 study, which came across for the National Audit Product, which was done in 2009. And there were some guidelines and potential solutions which came up with this. Now, can you see my cursor? I'm sorry, it's a bit complicated in here. I'm just going to try and simplify.
Yes, we can.
Thank you. Areas outside of the operating theater, or especially in ED, you have environmental issues, staff monitoring, and equipment factors are often compounded, which lead to increased risks of failure and patient harm. Now, this is common for all of the critically ill, encourage joint training, purchasing, and I don't understand what the purchasing would be, but anyway, but managing the critically ill would be important. In the ICU environment, it's important because ICU, as we've all seen, it comes with its own set of complications. You have the patient towards the head end where there is limited space, patient is always head up. There are numerous cables across, and there are infusion pumps, which you probably fail to count as many. And the bed space is obviously crowded. So the other thing would be how you can overcome this would be by using a common airway management trolleys and optimal positioning if you can. Equipment, if you go to the wards, not every screen or the patient monitor has ETCO2, so you will struggle to get ETCO2. Our outreach is quite grateful that they get all the monitors which we will probably need in here, but sometimes those ETCO2 monitors fail to work, and then we end up struggling while this patient is critically in need of an intubation. So it's not as easy as it would you think it would be. Monitoring, again, we've just said that. Training, yes, but the thing is there are limited low risk cases for training. That becomes another problem. So only thing is by doing local simulations we can come across with these, and human working factors, again, they are the most important. And as I discussed earlier, airway assessment, most of us wouldn't be able to do in a patient who is semi-conscious there or sitting with an NIV mask, because as soon as you probably take off the NIV mask, they start desaturating. So it becomes quite difficult with these patients. However, that does not mean that you can't put on nasal prongs or a high flow nasal oxygen and just have a look into their airway. But given the circumstances, most of us would have requested another backup help. You have your critical team with you and you try and intubate your patient. Now, patient risk factors are quite a lot of them because there's always a risk of aspiration. Not everyone is fasting. There is a gastric stasis as well. And oxygenation, either with CPAP and IV, they all can have resulted in gastric distension. That's the reason why we end up doing modified RSI. Our cricoid force is advocated with prompt removal if necessary, and a head up position. Difficult airways, increased incidence of edema, trauma, immobilized neck, prior intubation, tracheostomy. Urgency increases the difficulty as well, and you can recognize and be prepared for these kind of things is one thing. Always have a backup in hand. Make sure someone else can call, you can call for, and they will be quickly available when you are going to intubate the patient. Pre-oxygenation, we've just discussed this. Yes, and not everyone is going to be stable enough, so make sure you know what drugs you're going to use, whether you need to start them empirically on vasopressors or an inotrope, and urgency obviously makes things go wrong. Awake intubation, how often would we be comfortable doing this in patients? That's another question we have. Positioning, very restricted in terms of head end, spaces are limited. What you can do is try and see what you can do the best about it. Head end, sometimes on the wards, if it's an obese patient, you won't even find as many pillows during an intubation procedure. So everything adds, even small things like this can make everything go into a red flag zone. Sedation and agitation. Sedation holds airway risk displacement. They lose their spontaneous breathing capacity as well. And agitation precludes adequate preparation. Because if the patient is being agitated, that's obviously one of the signs of hypoxia. You would want to rush up and make sure you have a tube in hand, or the airway being secured. That means to say you're probably losing your critical thinking capacity at that point in time when you're just focused on the goal. So identify high risk, caution with the sedation. Airway maintenance, again, obviously you would have planned for what you want to do afterwards. Make sure that is not kept to the last of it. And in terms of staffing resources, nursing, medical, and healthcare professionals often lack anesthetic airway experience. Communication with the handover emphasized. Senior staff is not always present. Many lack out of hours cover. Routine airway care and maintenance are performed by nurses, and capnography is not universal, however. So we can overcome this by having a multi-professional training, check identified roles and define them roles. Waveform capnography has to be mandated, and equipment choice. That's one thing which is quite limited outside. training, focused training in the ED and the ICU, so they know what are the unique challenges each place has, and also how they can overcome them. Like focus on the risk assessment, prevention of hypoxia, and early request for advanced airway skills. Right, and surgical availability, rare, maybe distant from the hospital, preemptive identification risk of the patients, early intubation, not out of hours if possible, and front of neck experience. That's a bit rare. I did mention most of these have been picked up from something called as the NAP4 study. That's the major complications of airway management in the United Kingdom. This was the largest study of major complications of airway which was ever performed. It was a year-long national service evaluation which was endorsed by all the chief medical officers of the UK and collected data between September 2008 and August 2009. NAP4 captured the reports of major airway complications. I'm going to just go through this in very little details, not much. As you can see, the one in blue, which has all been all the cases, the highest incidence is for failed intubation and aspiration of gastric contents, which is what we are trying to aim and get it out. The total number of events reported in relation to anesthesia was 133. However, aspiration topped their list in about 23 cases. In most cases of death, it was anesthesia, which was counting for 8 cases of death and 2 of brain damage. And aspiration occurs more frequently in patients with risk factors. And if they're in ED and or in the wards in a worse condition, I wouldn't expect them to be without risk factors. Important findings which related to anesthesia cases in these were more than half of these patients were male, ASA 1 and 2. Can you imagine? And on the ED and probably on the ward, all we come across are ASA 3 and 4. If that's the status, look at what we're dealing with here. Age 60, and most events occurred during elective surgery under the care of anesthetic consultants, and aspiration was the most frequent cause. So in conclusion, this is for the NAP4 study. Airway management during anesthesia is associated with serious complications. However, they are quite rare. Optimistically, the incidents are about 16.9 million, which is about incidence of 1 death per 180,000 GA cases. We'll leave it there. So in summary, I would say RSI allows someone trained to do it, identify the cricod correctly, have contingency plans, be safe.
Right. So thank you, Krupa. Does anyone have any doubts now? I think, how shall I put it? No doubts mean everyone's sleeping.
Exactly, that was my take as well.
So before I would like to put some additional points, Krupa. They
Yeah,
were
sure.
very good. Like it was very nicely covered up, like how to do an airway assessment quickly, how to perform an RSI, what are the checklists that you need to put in RSI. I'm going to share my screen for a QR code. I don't know whether it is getting shared or no.
No.
Okay. Are you able to see the QR code?
Yes.
Okay, so I would like everyone to give feedback for Krupa on this QR code. Meanwhile, I'm going to discuss some additional points. Krupa, you rightly mentioned that in modified RSI, everyone did lot of modifications about the technique, the drugs, etc. The classical RSI, when NAP4 guidelines was being created, they used to use thiopentone and suxamethonium. Okay, and we had lot of modifications. Currently, our trust, I think, recommends rocuronium with propofol or ketamine. Am I correct?
That's correct, Amaya.
Huh. So I will always take this opportunity of one of in our anesthetic journal club, one of our colleague Anika Khan, she had presented this paper on RSI versus sham procedure. That means either you use RSI versus no RSI in emergency situation. And the main question that was put forth was that does RSI really prevent pulmonary aspiration or no? Okay, because NAP4 identified that in emergency intubation conditions, there is a risk of pulmonary aspiration. And The main important finding was that whether you use RSI or no, this was a non-inferiority study. So it's not a definitive randomized trial. It is not even using statistical power of significance. But it did show that whether you use RSI or no, there is no significant change in pulmonary aspiration. So the incidence of aspiration was very low. I think it was mentioned around 0.5 or 0.05%. I don't remember the exact figures, but it was present even without using RSI. And one of the postulates they kept was that there are still micro aspiration happening whether you use it or no. But definitely, yes. Problem with RSI was that it delayed the intubation period. That is the time from inserting the scope till the time endotracheal tube position was confirmed. So that is one thing. The risk of hypoxia was also noted to be not significant. But however, if we were to follow a trust protocol, if there are compelling indications like a patient, you know that he is a full stomach, it is better to use RSI. Another condition that we should think about using RSI in emergency intubation is when we are using suxamethonium, because suxamethonium is known to increase intragastric pressure and that will itself cause uh, uh, what they say involuntary regurgitation. If you are using rocuronium, probably you are still safe, that the risk of aspiration might be less. But if, like Krupa rightly mentioned, if we are going to assess the airway, if we have a slightest suspicion that it will be a difficult airway, it's better not to do RSI, given the benefit over doubt, and try to rapidly secure the airway as soon as we can. Krupa, I think, what do you say about this? What I mentioned just now.
I agree with what you're saying, Amaya. In terms of whatever Anika has presented, I do think there is not a higher chance of aspirations whether you do RSI or not. But having got that aspiration is one of the leading causes of complications or death, we would always want to do in a full stomach status or in emergency situations,
Yes.
assuming that it was full stomach, would be RSI. And we would mandate a cricoid pressure knowingly or unknowingly.
Yes, absolutely
I
true.
think all of us just tend to think that yes, full stomach, let's do it. It's not. It's more the benefit of a positive doubt than not.
Yes. And I think in another situation where, like you mentioned, that let us say the patient has, or even you have the slightest doubt this patient might be a difficult intubation, it is better to avoid RSI in this case and just secure the airway as soon as we can, isn't it?
Absolutely. Ultimately, securing the airway is a goal. You have aspiration, yes, we can try and deal with it as a second point, but you don't want to have a hypoxic brain injury, a cardiac arrest secondary to this.
Absolutely true. I strongly agree. Let me stop sharing my screen. Uh,
Thanks, Amaya, and thank you everyone for not sleeping and listening to me.
Now, Fatima, over to you. Your topic, if I'm not wrong, is about what are the airway assessment, isn't it?
Yeah. Airway management in.
Airway management and what are the airway adjuncts that we use. Am I correct?
Yes.
Sorry, I am having a very bad memory, so I'm getting old. Anyway, I'll over to you.
Yeah.
And
Can you see my screen?
yeah,
Can you?
we, yeah,
Yeah,
yeah, yeah.
we can see it.
Okay, so managing the airway in the critically ill patient, it's a situation that you can encounter anywhere in the hospital, not just in ITU, and everyone should be able to do at least the basics and know when, because anyways, you're gonna call for senior help. Most of us are not airway trained, so we just have to do the basics and waiting where the like someone like you come and do the rest of the job. So As an introduction, as you previously mentioned, so gonna go through a bit of anatomy. Airways, their upper respiratory tract can, which includes the nasal cavity, larynx, pharynx, and the larynx, that connects to the lower respiratory tract, which is the trachea, pulmonary bronchi, and the lungs. The main function is to ensure oxygenation, which is bringing the oxygen to the cells and to the body. And the second function is ventilation, which is getting rid of the oxygen that has been produced by the body cells. Once there is a compromise, either or in one of those functions, either we're not able to get enough oxygen or get rid of CO2, then we have an issue and we need to deal with it. So causes of airway compromise, there are many, and we can classify them to three classes. First one is when the cause is inside the lumen. Either the patient has vomited, aspirated, there are secretions, or there is blood, patient has a facial injury that is bleeding, or an epistaxis that is massively bleeding, and patient is aspirating. A foreign body, in maybe a child has inhaled, was playing with something and inhaled it. Patient also might be having inhalation of gas or fumes that can cause irritation and thermal injuries to the airways. The second class includes causes arising from the wall itself, like infections, tonsillitis, peritonsillar abscess, retropharyngeal abscess, epiglottitis, or floor of the mouth infections that they can, if an abscess arises, and it can compress the airways. Also, we can have trauma to the larynx, either by a blunt or penetrating injury, tumors of the larynx or the nasopharynx. We can have situations where angioedema or anaphylaxis arise, and there is swelling of the upper airways and causing patient not able to breathe properly. Finally, patients might have reduced GCS and lose airway when the neck muscle of the neck gets relaxed and the tongue falls backward. Third class is causes arising from outside the airway. Structures in the neck, either by injury to the neck, tumors of the neck, masses or lumps. Esophageal foreign bodies also, if they are big enough, they can also compress the airways. And finally, sometimes we can have patients with chest wall deformities or respiratory muscle problems, such as Guillain-Barré or myasthenia gravis, where they can no longer provide effective respiratory movements. So after we have discussed this, now we have to know how to know when a patient has an airway compromise and identifying those kind of patients. Here we have two scenarios. Either our patient is conscious or unconscious. If the patient is conscious, then it's a bit more obvious. He looks in distress, typically sitting upright and looking grasping for air. They might have a swollen red face or maybe even blue. You can see a swollen tongue, soothy sputum in case of thermal injury, neck hematomas if they have been in victim of maybe a road traffic accident, stab wound to the neck. You can look and see if the patient, asthma patients or COPD, after a long period of labored breathing, they become exhausted and breathing becomes compromised. Patients who sustain facial fractures, that's also one of the major causes of airway compromise. Also look for crepitus, palpate the skin, which might indicate a surgical emphysema. In case of the unconscious patients, you can notice that suddenly your patient or the nurse tells you that the patient is now making weird noises, he's snoring. This is an indication of partial airway obstruction. You can also, when you're assessing, doing your ABCD assessment, when you go to B, you have to look for the chest wall movements, abdominal movements, see if it's symmetrical or anything that might suggest that there is an issue. One trick that I've learned when doing this, I don't know if how common it is, but we can also look for the fogging of the mask. So supposing your patient is requiring oxygen, you're putting a mask, and normally it should fog, just like this. The picture on the the picture on the left, on the right. If you notice that there is no fogging, then maybe the patient's breathing is not adequate, or patient has stopped breathing properly. So after identifying patients' airway that have been compromised, we have to, what we can do to help with this. We start with basic airway management. We have all learned this during BLS and ALS. So there are some maneuvers that we can use. The aim of them is to have the better alignment of some bit of those axes. As you can see on the pictures, the upper one shows a very misaligned oral axis, pharyngeal axis, and laryngeal axis. First thing we can do is, before doing the maneuvers, we have to open the mouth, see if the patient's mouth has any secretions, any foreign body. Either we can do suction or take any foreign bodies if we can. Otherwise, if it's too risky, then we just don't go do it. Second thing we can do is the famous chin lift and head tilt. This will help open more the airways. You can combine it with putting a pillow under the neck. That would provide extension of the neck and open more the airways. As you can see in the second picture here, this angle here, if you compare from the first picture, the blue angle has opened, and this means that our airway has also opened and are better than initially. Just bear in mind that these chin lift maneuvers and head maneuvers and neck maneuvers, you're not able to do them if you suspect your patient has a spinal injury. So you're here limited with neck movements. And here comes the jaw thrust, which is a safer maneuver if your patient neck is immobilized or there is any issue with their neck. So how you perform the jaw thrust? The technique is simple. You just use your hand. With your little finger, you put it just behind the angle of the mandible. You put the rest of your ring finger, middle finger, and index below the mandible, and both of your thumbs on the chin. You lift the mandible with your fingers, and you push it forward with your thumb. This will allow to open the mouth and bring the tongue forward and open your airways. In a situation where you might find that your patient's body habitus can be a problem if they are obese, and in this situation, those simple maneuvers need a bit of adjustment. So if a patient high BMI is high, to help clear their airway, instead of putting just one pillow under or sheet under their neck, which will make the situation even worse, you need to put more pillows under their shoulders and under their neck. This will help the alignment of the axes even better and help open the airways. So now we have finished with the maneuvers. There are simple adjuncts that we can use to keep and secure more the airways. So we have two famous ones: is the oropharyngeal airway and the nasopharyngeal airway. The oropharyngeal is a hard plastic tube. You put it inside the mouth, and you have to get the right size. To get the right size, it's easy. You just put the tube, get it next to the patient's face. The mouth opening needs to be just above the lips, and the inner end should be at the angle of the jaw. The only thing a disadvantage with this adjunct is your patients should be deeply sedated, otherwise it won't be tolerated, and it can trigger the gag reflex and vomiting, which you don't want to have. So it's mostly in sedated patients or unconscious patients. The benefit is it will help lift the tongue up and keep the mouth open, and give more airway exposure. In case you cannot use the oropharyngeal airway, your patient is conscious or semi-conscious, you can use the nasopharyngeal tube, which is put through the nose, the nostrils. It's a softer tube, and it's more tolerated. Be aware that if you suspect that your patient has facial injury or nasal injury, it's a contraindication, because you don't know where your tube is going, and you might end up in the very wrong place and make things worse. So now we are done with the adjuncts. The aim of all this is, as Krupna said initially before, we have to if your patient is very unwell, then probably you're thinking of intubating, and the aim of all this is to provide with enough oxygenation and as much as you can to prepare for maybe intubation later. So after this, we can think of ventilation. And at this point, you have to determine your patient's adequacy of spontaneous ventilation, their own breathing. If they, how good is it? You can do that by checking their chest wall movements, the rates of the chest wall movements, the respiratory rates, their saturations. If you have an end-tidal CO2 or PCO2, that would be good, but you might not have it in a ward, and arterial gas will be just enough. If you notice that their saturations, despite having being on high flow oxygen, and all your maneuvers have been done, you have all your adjuncts, and still not achieving the target saturation, then you start ventilating. When you ventilate, you would need two things. You need a self-inflating bag and a correct size face mask. The face masks, so this is the bag valve mask. We can see it in every crash trolley. It has three parts. So here you can see that this is a reservoir connected with an oxygen inlet, where oxygen is connected to a source either in the wall or a cylinder. This part is the self-inflating bag. Here we have the mask, and in between the self-inflating mask and the bag, we have a valve here. Can you see the cursor? Hello?
Yeah.
Yeah.
We can.
Okay. Okay, so this valve here is the pressure valve. The aim of it is to ensure that when you are pressing over the self-inflating bag, that you're not giving more pressure than the lung can sustain and cause injury. So this mask comes in different sizes, and there are adult sizes, and even in adults there are different sizes. So to know which size you have is that the mask should be fitting from the nose bridge until just up to the chin. To perform ventilation with the bag and to be efficient, you should be doing it in the right way and getting it the right technique. Otherwise, you won't have satisfactory results. So for that, the most important thing is to have a good seal and to have a good technique. So how we, when we want to put a mask on or a face mask on the patients, it's just like when we do the jaw thrust, we put our ring finger just behind the angle of the jaw, the ring and the middle finger below the mandible, and the index and the thumb around the mask on a C shape, and you just have to have a firm seal. There are two techniques to provide the tight seal. Either one person technique, which is just one operator, but it's always better to do the two-person technique. One person will be holding the mask with both hands, and that ensures the best seal, and the other person will be pressing on the back. So at this point, you have got here, then again you have to review your patient, see how your saturations are doing, his respiratory movements, if you have again CO2 levels or oxygen levels, see if you are achieving the targets. When you are bagging, you will notice if bagging is easy or you're facing maybe some resistance. Then if you don't achieve your saturation targets, then you have just to check, is there anything wrong either in my technique or anything that I can simply correct while waiting for definitive management. So some causes of poor ventilation can be either related to a poor seal, like if the patient has vomited, there is blood on the face or any fluid that might cause the mask to slip. You just have to either to suction or to wipe their face. In case of elderly patients, they might be having dentures that they are not wearing or they lost it, and that causes the face form to be deformed. A trick to solve that is you might put some pack their cheeks with gauzes, and that's will a bit solve the problem. You might have patients with unstable fractures. This is a very tricky situation. Well, when you put a bag, you're putting pressure, which might compromise the fractures in itself and make situation worse. You can use the two-person technique and make sure that you're not putting extra pressure, or in this situation it's better to consider early intubation or other maybe neck front of neck maneuvers. If you have facial asymmetries, your patient have some deformities that are stable, not related to acute injuries, an advice of using two-person technique might solve the problem. If you feel that you have difficulty ventilating and you're noticing that there is some resistance while you are bagging your patient, this can arise in situations where your patient has obstructive sleep apnea. They have a big neck or a big tongue that is making you ventilation difficult. In this situation, you just have to optimize their neck position using adjuncts. You can use airway adjuncts with the bag, and that will optimize your technique. If the patients have asthma or COPD, maybe they have their bronchospasm is high, and you have to increase and to have aggressive medical therapy to reduce the spasm. If the patient has a big tongue, maybe consider, as we said earlier, oropharyngeal airway that would bring the tongue forward. Unfortunately, if you have a neck-ish situation where the neck is immobilized or stiff, there isn't much you can do, and bagging will be difficult, and you need to get to definitive airway management with alternative methods as soon as you can. So. So at this point, your patient is more likely requiring advanced airway management and a definitive airway management. So in advanced airway management, we have three types. So we have the extraglottic device divided into either supraglottic or retroglottic. We have the endotracheal intubation, which Krupa has brilliantly explained. And we have surgical methods of the cricothyroidotomy and tracheotomy. So for the supraglottic airways, we have two devices. We have the old generation of the laryngeal mask that used to have an inflatable cuff. They come in different sizes. The sizes depend on the weight of the patient, and most you will find this on the back of the tube. So as you can see, there is the tube that would be connected to the bag or to the ventilator, the cuff that is inflatable, and an inflation line with a valve. Now we have second generation supraglottic airways, which are the iGels. Easy to use. We were all trained during ALS to perform them and how to use them, but myself, I've never used them, and I don't know how wise is it to use them from an anesthetic point of view, or someone who is airway trained. But anyway, they come. They have a connector tube that connects the to oxygen. This part also has a gastric channel, which can also help in if you want to aspirate anything from the stomach or put an NG tube. And this part is a gel-filled cuff, which you don't need to fill it, and it's very soft. So how to put an iGel? The technique theoretically seems very simple. So we just have to lubricate the cuff very well. Make sure that you have chosen the correct size according to your patient's weight, and the tip of the end should face the patient's tongue, and insert it until it's makes a tight seal with the larynx of the patient. Connect to the intubator and try to get a definitive airway. Definitive airway is mainly endotracheal intubation. I won't go through again this intubation checklist, as Krupa has already explained it thoroughly. So the aim from here, what we have been doing so far, is to make sure that we have prepared our patients so that when we attempt intubation, we don't have any failure or any complications. Here again, the algorithm for tracheal intubation for critically ill adults according to the Difficult Airway Society. So as previously mentioned, there are we have to pre-oxygenate. Plan A is tracheal intubation. If you fail, you go through plan B and C, which is rescue oxygenation. You can try supraglottic airways. Once you fail here, you just have to declare a can't intubate, can't oxygenate situation, and in this and at this point you should have already called someone who is expert or trained in front of neck airway, which is the cricothyroidotomy. For the cricothyroidotomy, I will take you to a video which best explains how it's conducted. So, are you able to see the video and hear the sound?
Yeah.
Okay.
Fatima, there's no sound. Is that correct?
Sorry?
There is no sound. Is it like in the video?
Yes, it's in a video.
Okay, okay, fine.
Can you you cannot hear the sound?
No, I'm not able to hear anything. If there is any narration going on.
Let's see. Give me just 1 second. I'll see if there is any subtitles to it. Is this better?
Yeah, yeah.
Just this might seem that the video they are repeating themselves, but there is a different part coming after this. Okay, so yeah, that's it. Hello?
Okay, is the presentation over or
Yeah, yes.
okay? So while I'm sharing my QR code, does anyone have any doubts, any questions? I'm sharing the QR code. Any doubts or any questions from anyone?
No,
Okay,
that's great. Thank you.
okay. In that case, Fatima, I'll put some additions in
That's
this
cool.
presentation. Very good presentation in overall, and especially those diagrams about how the axes are aligned when you give the right position, and that is how you can successfully secure the airway, whether you use oropharyngeal or nasopharyngeal airway also, how to open it, how to oxygenate. All of them have been very well covered up. I'm just going to give you some additional points. So when you're giving jaw thrust, okay, the picture was very nice, which depicts how to give a proper jaw thrust. Just make sure always that you put a pressure on the bones and never on the soft tissue. Okay, that's because when you put the pressure on the soft tissue, all the soft tissue gets displaced inside the airway, and it actually worsens obstruction rather than relieving the obstruction. Then you mentioned certain contraindications for nasopharyngeal airway insertion. I'm just going to add some more contraindications, which everyone must keep in mind. One is if there is a diagnosed case of base of skull fracture or if there is CSF rhinorrhea, and if the patient has a bleeding tendency and he is bleeding a lot from the nasal passages. So in this case, nasopharyngeal airway is not a good option. And recently, when I attended the BLS class, so at that time, they mentioned to me that whoever is managing the airway, so he or she is supposed to hold the mask by two-hand technique, preferably. And whoever is doing the chest compression in BLS is the person who is supposed to squeeze the ambu bag after every 30 compressions. So I hope these are some new points that I'm adding, and I'm not, what shall I say, criticizing any of your points. So I'm stopping the screen share. So does anyone have any comments, any other suggestions? I think if this is the case, we can call it a day for today. And I think I had shared the QR code. I will share another link for feedback in next couple of days for both Fatima as well as for Krupa. All right.
Yeah.
So thank you everyone. Thank you Fatima. Thanks Krupa for your presentations.